Hello, we are going to go over ultrasound basics preparing for immersions. My name is Dr. Shannon Da Silva, and I will be going over this PowerPoint with you. This presentation is an introduction to nurse midwife sonography. We will go over basic terminology, hand placement, technique, and some of the more details that we need to have to prepare for your clinical immersion. I am a 90s child, and so back in the 90s, we had things called magic eyes. And so many times people, when they're looking at sonography, they feel like they're looking at one of those. Just blurry, it's hard to see. Sometimes when the sonographer, whoever is there that's skilled at this, will tell you, oh, look, it's a boy or it's a girl, or here's the head or the feet or the arms or the legs or the umbilical cord, or even more detailed things like the heart or parts of the fetal brain. Sometimes people feel like they're looking at the image on the side of this slide where they just are seeing black and white, and they can't see what they're looking for. And so I just want to encourage you, that's very normal. And as you look at sonos and you get your hands on and practice, you will feel more comfortable and your eyes will become more trained to see what you're trying to look for. So please use this as an encouragement to get as much experience as you can while you're in your clinical rotations to become familiar with sonography. And you will not by any means be an expert by the time you graduate in most cases, but we just want you to have a basic grasp on it and to be able to eventually, when you are a brand new midwife, be able to do the basic things that need to be done. So just take a moment and look at this photo. What do you see? Do you see it? I'm just going to give you a hint. It is a shape. The shape is a circle. For those of you that got it, congratulations. For those of you that did not, that is okay. I just want to encourage you that as you have more and more practice with sonography and looking and identifying the different fetal parts or landmarks, you will become more comfortable and you will start to see it and your eyes will become trained. Okay, so just another one. This is back to my 90s days, so you can enjoy this. But this is another one if you want to just give it a little try for fun. Let's see if you can get this one. So again, this is just for fun, but I just want to remind you that your eyes will become more trained the more you look at the sono images. And it will not be as hard as this. All right, so this one is an infinity sign. So for those of you that got it, congratulations. For those of you that did not, that is okay. That is not part of this. This is just for fun. So I always loved these when I was younger, so I hope that you enjoyed this little fun activity. But we're about to dive into sonography, so I'm excited to move on to that. Okay, so I want to start off this presentation with discussing a common pitfall and a situation where a twin diagnosis was missed. I talk about this in the very beginning because I want to stress the importance of why it is so important that we do a good job and that we have that we're skilled and we're not just doing sonography just for fun and giving diagnoses, that we want to make sure we're thorough, and I want to make sure that this course prepares you for an introduction. So many of you will have the opportunity in your clinical sites. Your preceptors may be doing ultrasounds. You may have the opportunity to go watch sonographers doing ultrasounds. And so we want you just to start off with a good understanding. So in this situation, the patient presented an early pregnancy and a transvaginal ultrasound was performed. The midwife got dating and viability and confirmed that there was a heartbeat, and then at 20 weeks, a second fetus was discovered. Yikes. So this actually was a real situation, and it was me. I was a brand new midwife. I did a very early sonogram on the patient, and then I did another one actually at around, I think, like 14 weeks or 12 to 14 weeks. And I only saw one baby, but it was a busy clinic. I quickly got the ultrasound, saw the baby, saw the heartbeat, and moved on. And unfortunately, when she was at 20 weeks, the sonographer told me there was a second baby, or told her. And thankfully, the patient was very understanding, and it actually ended up being a lighthearted, funny thing. They were happy about it, but it could have gone very differently. They could have been very upset. They could have really lost their trust in me as a provider, and it just could have been a very different outcome. So thankfully, she was, her and her family were very understanding and happy about the second baby. But all that to say is that I want you to learn from me. Wisdom is learning from other people's mistakes often. And so just remember, that this can happen. And this is one of the many reasons why we want to be very thorough. So when we're doing an ultrasound, some of the things that went wrong is I did not sweep through the whole uterus. I did not look in the longitudinal and transverse planes. I only saw one, when I saw one sac, I only documented that one. I didn't look to see if there was another one. I didn't look at the adnexa fully, or the fundus was not well visualized. And so just for you in the future, you always want to sweep through the entire uterus using both planes, and we'll talk about that more later. And just remember, at early pregnancy, the twins can be in separate sacs. So you can see here that that's a pretty big sac division, because they're di twins. And so if you just saw one in one angle and you did not get the view like this image has, you could miss it as well. And so it is just really important that you have good skills, that you, make sure that you are very thorough. So I hope that this reminds you, and just kind of a preface and a start of why this is important. So during this, we will talk about we'll talk about what a POCUS is. We'll talk about the certification process if you're interested in doing that at some point. We'll kind of briefly cover laws. I know we can't talk about all of them, and you all are from many different areas. So I'll bring up Texas, and then you can talk about, or you can look up your own states. And then we'll cover the basics of sonography. So waves, modes, probes, and knobs. So you'll become more familiar with that. So point of care ultrasound, this just means that it's an ultrasound that we can do. You can roll into the room and do an ultrasound. So different times we do this in obstetrics are to confirm an intrauterine pregnancy, or to confirm viability. We may do it to estimate the gestational age. So I know you may be familiar, and you'll find out this trimester that many times people don't remember their last menstrual period, so they'll make one up, and then things don't add up. And so having an ultrasound to be able to identify gestational age can be very helpful. We can look at fetal presentation. Is the head down? Is it breech? Is it transverse? We can look at the amniotic fluid volume. So sometimes we might do a fundal height, and it might be really big, or it might be really, unusually small. And so this can help us do a amniotic fluid volume, or if they think they're ruptured. Cervical length, especially if they're at risk for preterm labor. And then a BPP is often what midwives learn to do. And so this, we're looking at breathing, tone, and movement, and we'll talk more about that at one of the other PowerPoints. Some of the gynecologic applications that we might use a point of care ultrasound or POCUS is to identify if the IUD is in place. So you may have a patient that you can't find strings on when you do you do a pap smear, and you're looking to see if they still have their IUD in place. They may have abnormal uterine bleeding, and you're looking for endometrial thickness or polyps. An ovarian cyst or mass, or evaluation of pelvic pain or abnormal bleeding. Sometimes a point of care ultrasound is used for by midwives that are trained and working in certain settings. They may aid it with an amniocentesis. Often a sonographer is the one who does this, but you may work in a setting where that is you. So a midwife often is trained in limited ultrasound. And so I am a certified midwife sonographer, and I have been trained in limited sonography. So this includes confirmation of the presence and size, location, and number of gestational sacs, fetal pole, placental location, fetal cardiac activity, fetal presentation, cervical length, AFI with NST, and fetal well-being with BPP. This addresses specific, focused questions when an immediate impact on management is anticipated. So, can she continue pregnancy? Is the baby not moving as well as it used to be? Or is, we are checking for her AFI with NST, looking for dating. So all these things are really helpful for the midwife to be able to determine and manage patient's care. It is a process, and you can go to this website too if that's something you're interested at some point, not right now usually, but later in the program if that's something that you're interested in. The website outlines what is required for this, and it is you do have to meet certain expectations. You have to have certain ultrasounds, and then there is a test, certification exam that you can take. I believe that you have to be a certified nurse midwife to be able to take the test, but you can start working towards your competencies and the training later in the program. So this is just the Texas law. So it's important to know what your laws are regarding midwife sonography. So can you do them? Can you read them? In Texas, according to the Board of Nursing, the CNM practice is regulated under the APRN scope, and this is with the Board of Nursing. So it does not explicitly regulate ultrasound interpretations by CNMs. It does state that we can perform functions that we're educated, trained, and competent to do so. And so for me, I have my certification. And then the Texas Midwifery Act does cover certified professional midwives or licensed midwives as well. And so that talks about midwives being able to do care that is normal during pregnancy, labor, and postpartum, and that this could include ultrasound as a diagnostic tool within midwifery care. So you just need to know what your law is. There is many people have concerns about midwives reading sonos that they did versus sonos that a registered sonographer does. And so that will depend on your state, what is within the law. So we'll talk about ultrasound basics. So sound waves. Ultrasound uses high frequency sound waves to create images. So sound waves reflect off tissue to form 3D images. There's different types of waves that are used, and they vary by mode. So there's different modes, so that you can have 2D mode, M mode, and Doppler mode, and we'll talk more about that later. You can see the different types of probes release the sound different ways. So you have the phased array probe, and you can see it kind of fans out. You have the linear probe where it goes straight out, and then you have the curved linear, and that's the one that we use for obstetrics. So different types of probes and wave frequencies. So the linear probe often has a high frequency and a shallow depth. So we often use those for looking at veins. The curvilinear has a lower frequency, and it goes deeper. So like I said, that one we use with obstetrics and gynecology. And then the endovaginal One has a mid to high frequency for pelvic imaging, and then the phased array has a low frequency for deep penetration like cardiac or used in the emergency room. The endovaginal is the transducer that goes inside the vagina. So this is just showing the different ultrasound modes, just an overview so you can compare it. One of the things I do want to bring up is their different wave types. So some waves are pulsed, meaning they stop and go, stop and go, stop and go. And some waves you can hear and waves you can see, and they're used for different purposes. So often I'll have a patient, especially when I worked in a birth center setting, that wanted to limit the exposure. And I'll go into this a little bit more detail later. But you can see that the 2D B mode, which is what you normally see in an ultrasound. So that is when you see those cute little pictures of the baby's profile, or you see the baby's hand moving, and most of the times while you've got the ultrasound on the patient, that is actually doing a pulsed sound wave type. You can't hear it, but you can see it. And so it's not usually in real time, but you can see what's happening, and this is a low exposure. The M mode, this is also pulsed. You cannot hear it, you can see it, and it looks at cardiac motion. You'll see that. I'll show you images of what it looks like in a minute so you'll understand. And then the pulse Doppler is pulsed. You can hear it. So this is when the sonographer does the ultrasound and you can hear the heartbeat. You can also see it, and they do this when they look at the blood flow velocity. The exposure is moderate to high. So a continuous Doppler, those are the ones that we do with the handheld Dopplers. And a lot of times you would think, oh, that's much better, much safer than a sono machine as far as like the exposure to sound waves, which still is very, very low. So please don't think that this is concerning. But it is a continuous sound wave, and the exposure level is high. So often when I have a patient who is resistant, I've had patients that have been resistant to doing an ultrasound, because from my perspective, I would like to do an ultrasound because I want to know, maybe they're not sure about their period, or they had abnormal menses history, so their periods were really long, or they may have skipped periods in the past. And so in those cases, in all cases, I really prefer to have an early pregnancy dating ultrasound. But for the patients that specifically have these unusual situations or abnormal situations, I really recommend that they have an early pregnancy ultrasound for dating. And so often they're 12 weeks, 10 weeks, 9 weeks, and doing a 2D B mode where I can get the size, I can see the heart beating in the image, and I can really get everything that I need actually much faster than trying to search the mother's abdomen to find the heartbeats, and it gives me more information. So sometimes I'll talk about this, that I can do a sono much faster, and the exposure with the sound waves is actually considered lower. And so they may want to decide to let me do the ultrasound or to agree to the ultrasound versus me searching their abdomen and having that continuous Doppler. Now, again, please don't be worried about doing a Doppler on a patient, but this is just kind of that higher level of thinking of what is actually happening to the baby. And when we're talking to patients and they're wanting to avoid the exposure, this can be something. Now, we can't do ultrasounds on every visit, so that's not an option, but this is something to think about as you talk to patients. So there's kind of going back to that, there's the ALARA principle. And so this is what we talk about the exposure. So we want to have as low as reasonably achievable. So this is a core safety principle in ultrasound. This is we want to minimize the thermal and mechanical exposure to the fetus. And we want to limit the scan time to the lowest necessary settings. Time and use the lowest necessary settings. This applies especially in the first trimester with Doppler use, and so we'll talk about that in a minute. So the guidelines by gestational age, and so when we are talking about the ALARA principle, in the first trimester, we want to use 2D or M mode. So if you go back to that last slide, you can tell that the M mode is a lower exposure and it's pulsed. So we want to avoid pulse wave or continuous Doppler, unless it's medically indicated, because those exposures are higher. In the second trimester, we would use the Doppler if it's clinically needed. In those situations, that would be, so this is the pulse Doppler, so this is on the ultrasound machine. This is for the MCA Dopplers or umbilical blood flow with the umbilical artery Dopplers. In the third trimester, Doppler use is common for fetal surveillance, like with growth restriction and preeclampsia. So the Doppler use, especially the ones that are on the ultrasound, those are going to be a higher exposure. So why is the M mode safer than Doppler? The M mode uses a low intensity pulse to capture motion. The Doppler uses a high intensity to measure flow. The M mode has no audio and it has a lower thermal and mechanical effects. So that one is preferred in the first trimester to determine the fetal heart rate, and really up until 12 weeks. So the handheld versus the 2D ultrasounds. I know I mentioned this in the a little bit ago, but the handheld Doppler uses continuous waves with higher exposure. The 2D plus the M mode uses short, low energy pulses. So the imaging is often faster and more precise because you can find it quickly. I don't know if you've ever, you will if you haven't yet, but trying to search for those little babies. You can explain to patients that hearing is not always the safest option. And again, please, this is not to discourage them or to make them think that the Doppler is unsafe. These are really just those situations where the patient is more opposed, and you need to respect informed refusal and emphasize the ALARA principle. There are other alternatives could be appropriate. They're definitely not standard or recommended, but this could be serial HCGs. Again, this is just discussing these patients that are resistant to having any sort of exposure to sound waves, which is not very common, but just for your information.